Hello, my name is Iliya Goldberg and I have no disclosures for this presentation. I'd like to thank the SAGES committee for allowing me to present my research. Today I'll be talking about the impact of bariatric surgery on the development of diabetic microvascular and macrovascular complications. I'd also like to thank the rest of my co-authors for helping me put this research together. Type 2 diabetes is closely associated with obesity and has been on the rise in the US. Furthermore, diabetes is associated with both microvascular and macrovascular complications that can negatively impact quality of life as well as increase healthcare costs. Specifically, microvascular complications refer to end-stage renal disease, nephropathy, blindness, and neuropathy, whereas macrovascular complications are related to coronary artery disease, cerebral vascular disease, as well as peripheral vascular disease. Several studies have shown that both sleeve gastrectomy and Roux-en-Y gastric bypass induce the remission of type 2 diabetes, as well as reduce some of the complications that's associated with this terrible disease. Studies have also shown that there's improved short and long-term type 2 diabetes related microvascular and macrovascular complications comparing surgically treated and non-surgically treated patients. The purpose of our study was to determine whether there's an association between bariatric surgery and diabetic patients, as well as in the future development of diabetic complications. We specifically focused on microvascular and macrovascular complications in patients with both controlled and uncontrolled type 2 diabetes and baseline, and we compared those to non-surgically treated patients. We used the New York Statewide Planning Research Cooperative System, also known as the SPARCS database, to look for records with obesity diagnosis codes from both inpatient and outpatient data sets, and we focused on the years 2006 to 2012. We defined the different patients group as either having controlled or uncontrolled diabetes based on diagnosis codes, and we also looked at macrovascular and microvascular complications as defined by ICD-9 and ICD-10 codes from the years 2006 to 2016. We performed record matching using primary surgery records as well as non-surgery records in a 5-to-1 ratio, given the discrepancy in the total number of patients that have undergone non-operative treatment. Furthermore, we looked at time to diabetic complications for both operative and non-operatively treated groups. We saw a total of 88,981 patients. Out of those, 15,585 were treated with surgery and 73,396 were treated non-operatively. In the surgery group specifically, we noted a significantly lower risk of having microvascular complications compared to the non-surgery group. Specifically for controlled diabetes, the hazards ratio was 0.4, and in the uncontrolled diabetes group, the hazards ratio was 0.51. Furthermore, surgery also significantly lowered the risk of having macrovascular complications as compared to non-surgery patients. Specifically in the controlled group, the hazards ratio was 0.43, and for uncontrolled diabetes, it was 0.44. Looking at this graphs demonstrates the difference between the two groups. So specifically looking at controlled diabetes, we can see this red line showing non-surgically treated patients, and then and this green line indicates the surgically treated patients. As you can see, at 1 year, the incidence in the controlled group was 5.8%, 19.5%, and 30.7% in 1, 5, and 9 years. And that was compared to the surgery treated groups that showed a rate of 1.9%, 7.5%, and 11.9% at those same year intervals. In the uncontrolled group, indicated by this blue line and this purple line, in the non-operative group, the cumulative incidence was 10.3, 31.4 and 45.9 at 1, 5, and 9 years, whereas in the surgical group, the rates were 4.4, 16.4, and 28.4 at those same time points. Now looking at macrovascular complications, we saw somewhat of a similar trend. When looking at patients with controlled diabetes at baseline, the patients treated non-operatively, the incidence was 4.2%, 13.6, and 22.3 at 1, 5, and 9 years, whereas in the patients with controlled diabetes treated with surgery, the rates were 1.2, 5.4, and 9.9 at 1, 5, and 9 years. Furthermore, in the uncontrolled diabetic group, we saw a similar trend. The cumulative incidence for the non-operative group was 5.6, 17.6, and 27.5 at 1, 5, and 9 years, and compared to the uncontrolled diabetes, which was in the surgery group, which was 1.3, 6.9, and 12.7 at those time intervals. The other important thing to note here is that the plateau for the uncontrolled diabetic group occurs much sooner, around 6 years, versus for the non-operative group, which occurred closer to 10 years. Some of the conclusions from the study is that bariatric surgery patients with type 2 diabetes experience significantly lower rates of microvascular and macrovascular complications compared to the non-surgically treated groups. Furthermore, we noted that bariatric surgery was offering protective benefits for both complicated and uncomplicated diabetic patients. This reduced rate was also seen in the long term, including out to 10 and even 11 years. The rate of macrovascular complications for uncontrolled diabetes plateaued much sooner in the surgical group, around 6 years, compared to the non-operative group at around 10 years. The limitations of our study included the fact that our study was non-randomized, so there's certainly some selection bias involved. We also did not investigate the differences between the various types of surgery. For example, Roux-en-Y gastric bypass versus sleeve gastrectomy or gastric banding. Each one of those surgeries might have different impact on the development of diabetic complications that we did not elucidate from our research. And we also did not look specifically at data about the baseline physiologic status of the patients, including their insulin use, their total duration of the diabetes, their hemoglobin A1C levels, as well as their C-peptide levels. And these are all factors that we can investigate in future research projects. I'd like to thank you for your attention. And if you have any further questions about the research or the presentation, please don't hesitate to email me at this email shown here. Thank you very much for your attention.